Welcome to Longboat Key. It was a beautiful, beautiful sunrise this morning. So now we get to stay in this lovely room. Good morning. I'm Dr. Megan Indemauer, not Dr. Scott Jordan. You'll see him a little bit later. But welcome. Thank you, everybody, for coming. This should be an amazing event that Dr. Jordan was the prime scheduler and pushed us all to make this hopefully a wonderful weekend. I will actually do my address tomorrow. I was actually kind of working, so I wasn't even sure if I was going to make it this morning, but I was able to, so I'm very happy about that. So we're going to get the meeting started. So this year we have partnered with the GOG, so we've created more educational moments sponsored by many of the companies that help support us and our patients. So our first talk is sponsored by AbbVie. And so I'm going to introduce Dr. Jordan and Dr. Monk to start the meeting. Thank you.
Thanks, Megan. It's honor to get to do this, to chair the program committee again this year, and we're so thankful for the GOG and for our industry partners. Hopefully, what we've got planned. I said last year this is kind of like I've been working for a year or 6 months or so on a mixtape, and I finally get to play it for everybody. That's how this feels again. So thank you all for being here. Really excited. We think we've got a really great meeting, and thank you to AbbVie for sponsoring this first industry sponsored symposium. So again, I'm Scott Jordan. I'm going to be the moderator. Somebody made the decision that I should moderate Brad, who I think cannot be moderated. It's funny, and I worked on that all night. Yeah. So our session this morning is called Precision Decision Making in Platinum-Resistant Ovarian Cancer, Folate Receptor Alpha Expression, and Other Biomarkers in Contemporary Care. In support of improving patient care, this activity has been planned and implemented by the GOG and Jenna's wonderful team there. Really cool this year for our industry-sponsored talks. For most of them, we're actually offering ACCME credit. So this live activity is accredited for, that's me, is it 1.25 or 0.75? 0.75 category 1 credits. Obviously, if you leave halfway through, don't claim the whole thing, but hopefully everybody will stay. As we look to get started here, take a moment, scan this thing and do our pre-test evaluation. And this will help with building additional education on your specific needs, and so we have a little bit of a baseline pre-test. As you're doing that, I'm going to introduce not only man who can't be moderated, but also it can't be introduced because we only have 40 minutes for this. Brad has been a Florida GYN oncologist now for 3 years. So honored to have him as one of our newer members. Obviously no stranger to like every international and national meeting, but now he's also a part of Florida SGO, and we're honored to have Brad be here with us. So you want to introduce yourself?
I'm good.
All right. So I want to thank AbbVie again for supporting this symposium, buying us all breakfast. The following are our disclosures. This is definition of disclosures. These are actually all the GOG disclosures and my disclosures also. Our learning objectives, we're going to describe the clinical relevance of folate receptor alpha expression in platinum-resistant ovarian cancer. and its role in identifying patients for targeted therapeutic approaches. We're going to apply biomarker-informed decision-making, including folate receptor alpha status, HER2 PD-L1 expression, and clinical eligibility for weekly paclitaxel/Bev, in especially platinum-resistant disease. And then we're going to talk about some real-world cases as well to get the group involved here and pick Brad's brain on what I do regularly. It's called Brad when I have a question. So we'll do that here and involve y'all in that. This is sort of our outline. We're going to really try and stick to this because we're going to stay on schedule all day, and Fadi's in charge of times. So we're going to stick to that. So I'm going to turn it over to Brad for the actual meat of the talk here.
Thank you. So good morning. This is truly my favorite meeting of the year, believe it or not. And it was fun, and it'll be funner. It's fun. More fun. So first of all, the other funny thing that Scott says, about half of what comes out of his mouth was funny. Gotcha. Is we're going to have Monk give the first two talks so we can get him out of the way. So thank you for that. I appreciate that. These decks are created for you. You can email Jenna, you can email Scott, you can email me, you can put your junk drive right in the computer. So I'm going to go through them quickly. I could have had fewer slides, but this is a very, very smart, sophisticated group. So my intention is not to dwell too much on each individual slide, but to speak conceptually. Okay, and obviously I'm not always right. I want to hear your opinions. A lot of opinions here. And so we're here initially to talk about platinum-resistant recurrent ovarian cancer, which is a term that we don't use anymore. Regulatory term. And so it's now not suitable for further platinum. The most active agent, not platinum refractory, but is resistant, is platinum. So we're going to separate the idea of a regulatory definition versus a practical definition. Now, if it progresses on, that's a refractory patient, could be secondarily refractory. That patient is not a good candidate. So that's been around for some time now. And even ESMO, which is a little bit more progressive than we are, has factors that should be mentioned. Again, progressing during, symptomatic, platinum intolerance, and so on. So this is a new concept for the U.S. Platinum-resistant recurrent ovarian cancer is a regulatory definition. Well, why do they use it if it's not practical? They use it because there has to be a framework in order to get medications approved. So you're going to hear this afternoon another very nice symposium about. You'll see some of the same slides, so I'm going to editorialize more here. And obviously, Aurelia was the first positive trial in PROC. Aurelia taught us two things. The first thing that it taught us is that weekly paclitaxel is the most active single-agent therapy compared to liposomal doxorubicin and topotecan. It also led to the FDA approval of bevacizumab. It was done in Europe because it had concerns about GI perforation in the US. In fact, all studies in ovarian cancer were stopped until we had information here and also from Oceans. And again, I don't know why. I do know why. Someone would use liposomal doxorubicin and PROC. It's essentially an inactive agent with a response rate probably less than 5%. Give her tamoxifen. Or topotecan is also inactive. The degree of increased PFS and maybe even OS are significant. Now, the next concept I want to talk about is IO. There's a lot of misunderstanding. A lot of people think that B96 was let's throw it against the wall and see if it sticks. 4 of us, I don't know if Coleman is here, 4 of us sat down and said, look, let's take what we know. We know Aurelia works. Let's take 100, which was the base trial of almost 300 patients. It was active, and sometimes the number of lines of therapy. The Wenham regimen published, there's one here, see my buddy, Zeros regimen that shows it can be combined with When it can be combined with PAC, here combined with BEV, PLD is the wrong comparator. So you had to get the right comparator, okay, and you had to show that ultimately, with disease that could be measurable, that you could probably win biomarker informed. There's a lot of strategy, and this was at the end of 2020. It took us a year to get organized. We did it in 2022, and then while we were doing this, obviously Mirasol came. The Germans and the Europeans showed how, well, you're right. When PLD is added, and since we combined them together in the same study, this study was negative. But if we would have done a PAC study like you guys have ongoing, it would have been positive. So we knew we were on when we saw the results of OVAR 2.29. And then ultimately it's positive and improved around the world. And you're going to hear a beautiful, lots of debates here ongoing. Also, Rosella is here and Mirasol is here. And to think that the frontline trials, which were launched already, Athena, Combo, Duo, Keylink, First, had anything to do with that is naive. That's a different setting. Checkpoint inhibitors don't work that well in ovarian cancer, like they do in endometrial and cervical. If you do an endometrial cancer, cervical cancer trial with checkpoints, it's going to work. If you do a checkpoint inhibitor trial in ovarian cancer, it's probably not going to work unless you do the right study. It's a really, really important. And it doesn't mean that this study is negative B96. It means that all those other studies were wrong and ill-conceived. We did it. You know it. Why do we add bevacizumab? We added bevacizumab because that is the best regimen. That's what Aurelia told us. And we paid for the bevacizumab. We didn't want patients to get bevacizumab only because it was available. So you're from weekly paclitaxel and pembro versus placebo with or without bevacizumab. And then here's the defining theme for B96, Rosella, and Mirasol, that the hazard ratio of PFS is very similar to the hazard ratio of OS. It's weird. So if you look at the medians are very small, a month or two. But since the hazard ratio is preserved for OS, the medians for OS, which is a bigger number, 12, 13, 14 months, now all of a sudden the OS is important. So the relevance here is not the PFS, but the OS. And I don't know why the hazard ratio for PFS is the same as the OS, the hazard ratio for OS. So and they have CPS and intent to treat, and 75% of the patients were CPS. When you say, no, that's not the PD-1 positivity rate. Yes, it is when you use the Agilent platform with a 22C3 clone and a CPS score of 1 or greater, okay? So this is why it got FDA approved, 4 months. It's the longest overall survival that we've ever seen. The intent to treat, the rest of the world has approved it in CPS greater than 1, and the reason is right here, less than 1, the hazard ratio is 0.98, so that's why it wasn't approved. All right, response rate 53%. Well, you say, well, an antibody drug conjugate has a response rate of 50%. Yeah, I know, and so does this. You say, well, that's a regimen. Well, yeah, it's true. But so the antibody drug conjugates which are in development today will be compared to this, whether they like it or not. Okay? So the adverse events were not new. The other difference, though, is that if a patient stops paclitaxel, they can continue bevacizumab as a maintenance. This is not relevant to Rosella because relacorilant helps overcome chemotherapy resistance and is not active as a single agent. Relacorilant and glucocorticoid receptor antagonism is real. Just like the skepticism, well, IO doesn't work in IO, or skepticism here, it is refuted with science. And because it's a glucocorticoid receptor antagonist, you have to add it to a chemotherapy backbone that doesn't have dexamethasone, which is albumin to paclitaxel rather than cremophor. You did it. You did it well. There was a phase 2 trial that informed this, that showed that a continuous regulation of the receptor just caused a downregulation of the receptor. You have to pulse it so that the receptor is blocked, not downregulated. So it's given the day before, the day of, and the day after. And as they say, the rest is history. A small difference in PFS, 1 month, but the hazard ratio is preserved for OS. And with the hazard ratio that's preserved, now all of a sudden the median is relevant. Now all of a sudden get the FDA approved March 25th. And we'll get to, Dr. Jordan will teach us how you decide between these two regimens. Glucocorticoid receptor antagonism is a good thing. Your blood pressure goes down, your blood sugar goes down, you have more energy. The reason you're tired in the morning is because your cortisol spikes in the morning. Maybe you should take a dose of relacorilant rather than Red Bull. All right. So let's talk about antibody-drug conjugates. I'm going to wrap it up. There are 3 antibody-drug conjugates. You're going to hear about them over and over again. Obviously, tissue factor, very important in cervical cancer. MERV, we're going to talk about it very quickly. TDXD, which we'll also touch on it. Now, the topoisomerase linkers are good and bad. You say, well, I like topoisomerase inhibitors. They're more active than the tubulin payloads. Okay. Until your patient has grade 3 GI, or until your patient has grade 4 neutropenia. So yes, this may not be as active, but this has higher GI, higher marrow suppression. This can be combined with carbo. This probably can't. This is active after that. So they're big concepts that help us in practice. We like tubulin, we like topo. Yes, we can probably use them one after another. And the adverse event profile is not related to the target. The adverse event profile is relative to the payload. So TDXD, the deruxtecan, is a linker payload. It's a proprietary like vedotin on tisotumab. All of this has been well documented. And so I'm going to now move on to folate receptor alpha. Folate receptor alpha also is mired in controversy. If 2+ was the threshold for folate receptor alpha, moderate, let's say moderate, not 2+, moderate, mediums, okay, their first trial would have been positive. Remember, the first trial was negative, and then we did it again with the right biomarker. So the biomarker matters. High level is defined as 75% of this plus or more. It can be measured. It is subjective. If you don't like 74%, get another pathologist to read. It'll probably be 75. It could be 73. So Mirasol was really the first breakthrough. Mirasol, again, is a single agent approval. Rosella and B96 are regimen approval. It is what it is. I'm not sure which is better, which is worse, but as I say, Mirasol can stand on its own. This is not dose optimized. What's the right dose of mirvetuximab? I don't know. What's the approved dose? 6. It doesn't satisfy dose optimus. Dose optimus is a regulatory law, or opinion by the FDA that you have to prove that a higher dose 6 is worth the added toxicity compared to 5 or 4. That's called dose optimization. So again, PFS, hazard ratio, at the median, 1.7 months, 1.64 months, but the hazard ratio is preserved. OS is here, FDA approved. Now we have 3 regimens. 2 are biomarker informed, B96, CPS greater than 1. Here, folate receptor alpha, 75% of the cells are 2+ or more. MERV, because it's tubulin. Remember I told you topoisomerase has more GI marrow. Tubulin has more neuropathy. It's on the next slide, neuropathy. And there are these idiosyncratic adverse events such as deruxtecan payload, which has ILD pneumonitis, and here, which has the ocular. And if we learned anything from TD, which is a good medication for cervical cancer patients, we learned how to deal with ocular adverse events and go see the eye doctor. So you have to be intentional. You see, and I say the eye doctor because it could be an optometrist, not an ophthalmologist. You see them every other cycle and you do the drops. The drops are built generally right into Flatiron, which is what I use, or Epic or Cerner, and it just goes, and the nurses know how to do it. And we have wonderful pharma partners that have trained them. So we're not stopping. You're not stopping. You're doing all these trials. We had a wonderful dinner last night with a biomarker company. I said, why don't you give us the expression of all these in your report? They said, it's there. I can't wait for them to show me how to read their report because I don't know. So, and AI did not make this, I did. So folate receptor alpha is a validated target. If it's a validated target, then let's change the tubulin payload and make it a topo payload. And lift your 3 large companies, now let's do that. Sophie-M, Rena-S, Torvu-SAM, folate receptor alpha, topoisomerase payloads, all in phase 3 trials. And these are the studies that you're doing in PROC. But the control arms have to be changed because now the control arms have to include B96 and Rosella. And that's going to create some anxiety for somebody. So this is cool. Again, I want you to have this. This is, and these are not meant to be comparators. These are non-biomarker. These are early phase. You saw the tubulus and NaPi2b resurrected with a 50%. There's a company that makes an antiviral therapies that bought them for lots of cash. There is several of these that you're doing. This is a study that Rob Holloway's helping us with. Very exciting stuff. And then these the biomarker selected cell cycle molecules. PuxySam was also at SGO. Pretty cool, right? PuxySam, B7H4, very exciting. So aren't these cool slides? And I didn't make that either. So we got the folate receptor alphas here. We got the 2 B7H4, CDH6, NaPi2b. Okay, and you can take a picture or you can just email it. I'll give it to you. And I probably, as Herzog says, he says, I'll give you permission if I use your slides. I said, no, you won't. I have half of your slides. They're yours. All right. So we're in incestuous. Is that okay? So this is what they look like. RDXD. That's pretty cool, right? That's cool. And you're doing this, and you're doing this in recurrent and frontline, and on and on. Here's another one. This was just at the SGO. So this is what dose optimization looks like. Obviously, 5.8 is more toxic than 4.8. But this is active. So we can justify the increased dose. That's what dose optimization looks like. If the activity was similar, and obviously more is more toxic, then we would have chose that slide. So that's, again, a teaching concept. That's a dose-optimized regimen. I'm really going to speed up here, and it's thank you to be here. We'll talk a little bit about other antibody-drug conjugates in my next talk. Happy to be here, and this is my favorite meeting, and if you have a different opinion, we want to hear from you. Thank you.
You want to stay up there? All right.
You're the boss.
So a couple cases here, and you nailed it on time. You were perfect. We're perfect, John. So,
Sergeant of Arms right there, Foddy. Yeah, when it thumped me.
So we're going to talk about a couple cases here, and we'll get Brad's thoughts and maybe open it up to everybody and see if anybody disagrees with Brad. So this was a lady who had a debulking surgery up front for stage 3B high-grade serous ovarian cancer in 2013. She got dose-dense carbopaclitaxel. And this is like vintage G1 oncology vintage case. Dose-dense carbopaclitaxel. And then she, it's like watching an old TV show, and it's in standard definition. So then she had a recurrence then. Is it me? Am I doing something wrong?
That's not an issue. I'm having over here.
All right. Okay. She had a recurrence in a paracolic gutter. at the end of 2017. So she had a platinum-free interval of like 3 years. So pretty safely started on another platinum doublet, gemcitabine. Unfortunately, she progressed on 3 months of completing therapy. Now, this is her recurrence from prior to the platinum doublet. Would you rebiopsy her after she became platinum? I know we're not supposed to say platinum resistant, but would you? Does you think it changed?
So I think he do biopsy a rebiopsy a patient. Just to check your biomarkers, but you check near gorgeous. But if you do rebiopsy it, be like, well, might as well profile her. Is this feedback? Well, sorry. So what I but like it's been 3 years. She's like, what do you need my cancer's back? Yeah. This is the thing on my casket, and I feel fine. So generally, I would rebiopsy it just so that we're all on the same page.
No, but this is a rebiopsy from the first recurrence, but it's prior to her progression after 3 months of carbogem.
Right. But that's the rationale that goes into rebiopsying it. Patients want to know what they have. We actually have an intervention data as part of our practice. So we don't have to keep teaching.
So her NGS testing showed a microsatellite stable, tumor mutational burden indeterminate, HER2 1+, PD-L1 CPS 11, and folate receptor alpha 80% 2+. So what are your considerations here when you're thinking about which agent of all of those things, because she falls into a number of categories? What are you thinking about which you're going to pick?
So one of the things that creates controversy is when you start to think off-label. Because off-label is off-label, then off-label could be lying stuff.
So I had a tendency, particularly away, like practices constructed, they bomb people. You got to keep the on the right track because of creating reimbursement challenges. So if I look at this, the HER2 is negative, 1+. The PD-L1 is positive, this AP rating of 1, and the FR alpha is positive to the straight into 75. So those would be on-label approvals. My question is, could you take weekly pack, or and also full at FR alpha? So MIRV is better tolerated. That in the, and I didn't show it, but we can talk about it. The Mirasol quality of life shows that MIRV is better tolerated in single region chemotherapy. Just what it showed. And whether you say the other day, well, I see it in the clinic every day.
Yeah. I mean, I think everybody in the room would agree that.
Yeah. So to sit here and to say, well, should she get, let's say, B96 or Rosella? My mind, it's away from the emperor. It really overall survival there, FDA approved and recommended. How could I be wrong? Doesn't mean it's malpractice to give her B96 or Rosella.
Do you think sequencing makes, if somebody has a different opinion and somebody's like, no, I'm going to give B96 or Rosella, that's new and exciting. Do you think sequencing makes a difference in that setting of going back to maybe a microtubulin inhibitor with MIRV?
I don't know. The sequencing is a little bit of a misnomer. So this is a good prognosis patient, and this is a Dave O'Malley case. So that's why we're gonna see some cool.
That's why she lives so long.
It's true, actually. So in B96 and Rosella, a third to half of them, that was their last line of therapy. So this is a good prognosis patient. She only had 3B when she was diagnosed. It's been a long time, but the typical PROC patient, the decision you make is probably going to be her last treatment, or at least half the time, right?
Sometimes that speaks up more into tolerability, right?
All of it.
So really went on a trial and got none of these things. She got a weird one. This thing in case they get it going, and then it's like,
If you have feedback here, right?
oh, okay, all right. So then she started another clinical trial and that was Merv plus Bev. She made it up until cycle 27 at a delay. So she did actually pretty well. Again, speaking to tolerability. She made it to when the clinical trial closed, went on expanded access, and commercial supply Bev, and made it out. So she was on this regimen for 3 years, until October 22. She elected to take a treatment holiday, and a year later, unfortunately, presented with brain mets. But this is 10 years after her original diagnosis.
Right. Which is never enough.
Right, for sure.
And so, but this shows what clinical trials can do. And we won olaparib was a good swing, right? But it was a slider in the dirt and you swung over it. But here got Merv before it was ever available. 3 years before it was available. Pretty cool. And obviously she was folate receptor alpha high. O'Malley didn't really know that was as big a deal as it is, and got Bev, and Bev is an important agent. The interesting thing here, when you look at your patients, some patients may not have really had cancer when you treated them. What are you talking about? That swollen lymph node, that whatever may have been whatever. This patient had in her mind, I'm cured, it's been 3 years, why do I need that stuff, right? Until she got a brain met and died. Armchair quarterback, I'm really good at it. The next day we should have ran the ball on the 2-yard line rather than thrown the pass. Beast mode. Remember Seattle and the New England Patriots Super Bowl, which was in Phoenix, which I was at. But it's a real case, so that's why it's fun. Not something that we show the slides. The slides are pretty cool. These are
Sorry, I forgot about
O'Malley slides with permission. And you can see that and O'Malley has been one of the key proponents, as the people in Boston and several of you. But this is tumor shrinkage, and it takes time to go away. And when this patient has cancer, right? This is not a short axis 1.6 millimeter lymph node. This patient has cancer, but after 3 years decided to stop, go to the next one. So that's, I think, inspirational, because she got it 3 years before it was approved. It also is inspirational to us that even though she lived for 10 years, it's not enough.
Yeah.
So I put this slide together. You may not agree with it, but there are 5 things when I see a PROC patient that I look at, and I would invite you to do the same thing. And the first is my patient eligible for weekly taxing? Why wouldn't she be? Because she has neuropathy, right? Which is pretty common after these multiple platinums. And if she's not eligible for weekly taxing, she's not going to get B96 or Rosella. And you can make that determination very quickly, okay? If you like bevacizumab for your patient, you can't give her Rosella because Rosella doesn't include bevacizumab. So if you say, oh, she's good for weekly pack, she needs Bev, hasn't had it for a while, that is a B96 decision, okay? You remember that we launched olaparib, remember those 50 milligram capsules, 8 of them in 2014 with olaparib. We learned that it's pretty difficult to get an oral anti-cancer therapy in PROC because of GI dysfunction and ascites. So if she can't take an oral, she ain't getting Rosella, okay? And then the number of lines of therapy, the reason B96 is 2 priors is because that's where the indication for Bev is. Okay? So if she has 3 priors, then all of a sudden it is Rosella or Mirasol. And the biomarkers is part of it. It is the last thing, not the first thing. They all fit together, though, almost equally. And this patient that O'Malley had, this is a big deal. And so this is almost always positive, 3/4. This is almost always negative, 35% or so, 40%. And this is essentially never positive in high-grade serous ovarian cancer, never 5%. So you can take this, and this will clarify 80% of your PROC patients. And there will be some where it'll be difficult. Now, if you start getting off label, well, I'm going to give her Merv-Bev, it's okay. Or I'm going to give her HER2 because we know that HER2 works in the 1+. It actually does. he may not get it paid for, but against off-label. So you have to decide from a reimbursement standpoint, do I just follow the label, which is what I do, or do I do NCCN because it's compendium listing, I think, and get it paid for, or do I, I don't think Slomavitz this year. Slomavitz said I can get anything paid for in Florida. So I'll just, if I have 1+ and want to do it, then I'll just do it. And do whatever you want. But these are the thought processes that we go through. Tell us how you do it.
So my question for this patient is, in a folate high patient that can tolerate Bev, it's on compendium.
I don't know.
I mean, you invented Bev.
I didn't invent
so
it. So if you progress on Bev, it's probably not doing much.
Right.
But on the other hand, if she had, let's say, Bev in the front line that several of us do, and then ultimately, or even in PSOC, and here she is, she hasn't had it, I kind of like it, I probably would. I mean, bevacizumab is like, you've heard me say, like peanut butter, it goes with everything.
Yeah. How many, show of hands, how many would give this patient Bev in the setting with MIRV? If you're settled on MIRV, how many would give
3+
Bev in a high okay. So it's
to your point, why not?
It's Tom and me. Yeah, that's my thought is why not?
The reason why not, which I don't agree with, is, well, maybe she didn't get GI perforation. Probably not. She's smart. Probably not.
How many and between the 3 regimens that she's maybe eligible for, between B96, Rosella, and MIRV here for this patient, how many are picking B96 for this regimen? Like Brad says, I don't think there's not a wrong. There's definitely not a wrong answer. And I don't think there's a right answer either.
Sequencing, if you were to give her B96, she's probably going to be alive and be able to get MIRV later. And the reason, you can speak for yourself, but the reason you probably like B96 is because it has a higher, it's lots of good stuff in there, right? So it's intense. She's probably going to tolerate it well, so I want to do the most for her. I get it, it's more work, might even be more toxic, but this woman has seen what commitment to survival looks like and how you can stay alive. Yeah.
How about Rosella? Anybody giving this patient Rosella before MIRV? Or holding that off? All right, and then I guess everybody else is MIRV or not participating this morning. So all right, perfect. All right, good. All right. We got another case. And we're doing okay. We're on time still.
What's wrong with that?
That's awesome.
Okay.
This is a 59-year-old with 3C ovarian cancer. She's BRCA wild type on her germline testing, and then her NGS shows HRD score 44, HER2 1+, folate 70%, and a CPS score of 6. She gets neoadjuvant chemotherapy. I must have been her surgeon because I recommended neoadjuvant. It wasn't Tom. So she got 3 cycles of carbopaclitaxel Bev, and then she got an interval debulking R0. Again, I must have been her surgeon, and 3 additional cycles after that. She normalized her CA-125 down to 25, disease-free. Unfortunately, 2 years later, platinum-sensitive recurrence, and she gets Calypso, another vintage, a little bit of a vintage regimen there.
Would you have given her Bev here? Bev again?
Yeah, 2 years. She doesn't. So she's been on maintenance Bev for a year, and then she's been off of everything for a year.
I get it.
Yeah, for sure.
Okay.
What if she progressed while she was on Bev? Would you give?
I generally don't. So if we learned anything, remember the Boost trial was frontline 15 months versus 30 months.
Mm-hmm.
That's another example where I was wrong, because I thought more was better. So you'd think that 30 months would be better than 15 months in the frontline ovarian. It's just not.
Yeah.
And so no, I don't. But that doesn't make it right.
Well, we're having this discussion right now with a patient, but I think
she's progressing on it.
I know. I know.
Here's what we used to say. Well, it's keeping the fire smoldering. If we stop the Bev, it's going to flare. I just don't think that's true anymore.
Yeah.
Now, we have randomized data that says progression on Bev, go to chemo Bev after that, and this may not be it.
What Wendell said, what Dr. Naumann, I mean, it's,
There is data support.
so this is, and we're all friends, but this is why people say, Monk, you changed your mind. You're right, I changed my mind because I got some new data. So when Wendell teaches me, I change my mind. I mean, that's what we have to do here. I get stubborn and attached to these concepts that Bev goes good for Bev for life. It's just not true.
Yeah. That's why we'll have that question on the CME thing about what did you change in your practice as a result of this discussion? Carbo, liposomal doxorubicin, and then unfortunately she has her second recurrence then 4 months later. So what are our options here? I'm going to leave the biomarkers up.
So the other thing that's interesting here, how many of you would give this patient platinum again? Although she's, see, right? So although she's not at this juncture?
No.
It's been 4 months?
I'd wait a little bit.
It's been 4 months.
What platinum regimen?
Cis Jim, Tom?
Cis Jim. That's what. I like to sneak another line in there before Cis Jim.
That's what Dr. Herzog says. So
I heard him, but he doesn't have a microphone, so I get to take credit for it.
So extending the platinum-free interval is effective?
Yeah, I think so.
Succeed. Why she never did.
So, because she should have. Yeah?
You were
Okay.
Yeah.
Thanks, Tom. She should have.
So coming off of carbodoxorubicin with folate medium, HER2 1+, anybody's answer change for this one? Are we still going with Merv Bev on compendium, or is this a B96 patient? So show of hands.
Or Rosella.
Or Rosella. Yeah. I was going to get to it. I wasn't leaving it out for sure. Gabby, don't worry. So all right. So we'll start with. So who would give Rosella to this patient?
how far away is she?
Oh, good question. Half hour. Yeah, she's willing to come weekly. All other things being equal. I don't know. Rosella? B96? Merv Bev?
So this is the reason this is interesting, because my patient goes to see you guys, whoever, Holloway, Rutherford, all you guys, and they're like, well, he told me I should get something else. And yeah, that's reasonable. But imagine how confusing it would be as a patient to go to Orlando or go to Tampa areas. So, right? And that's why the best thing to do, frankly, is to call me and say, what do you think? And then you can say, I talked to Monk. After second thought, we think you should get. And that way we make it less good.
So is it our job as a society in SGO to list a really easy, user-friendly, you should do this. Like, why is this hard?
So in renal cell as an example, the NCCN, whether it's the society, it says this, that, right? It's bladder, it's you're gonna, I think when your guys is, you're gonna show the NCCN recommendations, which I didn't show. We tried to make the two satellite symposia different. It's impossible to figure it out. And so that's the challenge. You guys aren't you the president of the SGO? Don't laugh at me, Becca. So the reason it's not done is because in several people's minds there's so many shades of gray. I think it's easier for people to know. But here's what she lives far away. She doesn't want to lose her hair. There's a lot of soft concepts. It's a great question. I'm glad you're the president. I voted for you. Elect. And several of you in this room were president. All right.
Yeah, I think I'd hold off on MRF for this patient. I don't know. I don't think there's a right answer. I think this is
There's not a right
a
answer.
conversation for
That's why you wrote the case.
yeah. So, how about clinical trial?
Well, clinical trial is the NCCN recommend of all the recommendations. That is the challenge, and Dr. Herzog and the GOG and all of you have tried very hard to bring these trials, but it's hard to operationalize that. They're opening and closing, and if they have a crooked toe, they're not eligible. The most common reasons for not being eligible here is a hemoglobin less than 9.
Yeah.
It's had a lot.
Albumin less than 3.5.
So we generally don't do that, but the 9 is everywhere.
Yeah.
But both of those.
Yeah.
And it's not her fault. And hemoglobin of, I actually did that. I actually called LabCorp and I said 8.9. The guy says, well, that's actually a range. The range is 8.7 to 9.2. And I sent the sponsor. I said, see, that's over 9. It's the range. He says, no, it's 8.9. So these are the challenges. You find things on the CT scan, this, and oh, that's ILD, right? So these are the things that can wear you down. GFR is another one, particularly if you have hypertension or if you're a woman of color, or that's right, Wendell. Okay, but it is the right answer. So here's this is another O'Malley point. This is why you have 3 PROC trials open.
Yes.
Right? Because they're not exactly the same eligibility, but if you have 3 PROC studies open and you don't enroll to them, then your practice or cancer center gets really agitated. It only takes, in my mind, 3 or 4 per study to make the numbers work from a return on the effort. 3 or 4 is a lot. Listen, if you do 3 or 4, you'll get authorship on many of these studies, right? If you do 6, you'll definitely get off. And that's what.
Have I done 6? I don't think I'm close. That's aspirational. But yeah, I mean, we have a lot of exciting clinical trial options for like exactly this patient. That's
exactly this patient.
Folate medium.
All those ADCs I showed you.
Yeah. So and your B7H4s, all that. Yeah.
All of it.
So very, very exciting stuff. So hopefully in the next, I was excited about SGO this year because all the data that Wendell's going to talk about is stuff that trials that all of us now have open that we can point to and say like, oh, this was the data from phase 2. We're really excited about this. And guess what? We just opened this trial, or John's got this trial open and I can send my patient down to Miami or Brian or Brad even. I can send, sometimes my patients will go north. That's, I'm so excited about where this talk will be next year,
Let's open it up for questions. We have maybe 5 minutes, just because you.
Anybody have any remarks, questions,
arguments, rebuttals?
Yeah.
And Pharma can ask questions. Right. Hey, thanks, Rob.
What the other two do at the approvals are is already combat expanding by line of therapy.
I don't know if Tom, if you heard that. So, almost all of our studies are 3 priors, unless you've had MERV, then you have 4. Is there any talk about maybe doing 4 or 5?
Like, are we going to do beyond the 6?
Yeah.
Right.
It's what we're strongly recommending to the sponsors. There's some reluctance to go to 4 to 5 because it's a little uncharted. We try to argue that it's a responder phenotype. If they've come that far, they're probably a responder phenotype and otherwise appropriate for a trial in terms of performance status and critical organ function, then they'll be fine. But there's nobody wants to test their drug again, on line 5. There's concern, obviously, of bone marrow reserve and everything else. But
if you're
going to have to do it, or we're not going to be able to. Yeah.
present B90 data to pay and say, I want to try you on a phase 2 trial. We're not sure whether to offer it.
Well, the FDA is saying you can't do that, really. The FDA is saying that if the only option in a B96 or Rosella eligible patient is liposomal doxorubicin, it's just not an acceptable control arm. And so the challenge is the sponsors are slow to make change. To Tom's excellent point, you got no chance. We have so many PROC studies, and for these agents that Wendell's going to show us, and I won't name them by name, but you got no chance of beating Sofiam and Torvusam and Rina-S and all these. If I didn't mention somebody, I'm sorry, but they got good agents, right? So you got no chance. The other question is ADC after ADC. Because if you fail a topo ADC, like all of those that I showed, then now all of a sudden the bar is different, right? So it's true it'll probably only work 30% of the time for a response, but that's better than PLD or topo, right? But again, to Dr. Herzog's point, very hesitant. So they said, well, I don't want to get relegated to post-topo ADC as an indication. That's a greedy statement. You're going to be lucky if you're even in the playoffs, let alone win the playoffs. That's what I say, right? So at least if you get a 8 post ADC approval, you still get an approval, right? But they're very hesitant, and it's challenging for us as we talk to sponsors. Several of them are here. How the decisions are made is very complicated. Needless to say.
Yeah, man, I think the worst thing, like one of the worst feelings I get is if somebody calls me, like somebody in the area calls me and says, you have a trial for this patient. It's like, how many lines has she gotten? I'm like,
I know.
Sorry.
Well, also cervical cancer too. Eric, I don't see Eric Schroeder. We were talking maybe yesterday. So what's going on in cervical cancer? So what, after you fail TV, good medication, they're nothing. They're no trial, maybe, and that's a phase 1.
Yeah. There's a great phase 4 for TV though. That's occurring right now.
If you fail TV?
No, a phase 4 for TV for second.
Oh, phase, right.
Yeah.
This is a TV
Needs a
failure.
new PI though, that trial.
Yeah.
So once you get FDA approval, there are called post-marketing requirements. So in other words, the FDA will give you approval Mirasol, but you got to figure out the dose. That's what happened. We'll give you the TV approval, but you got to figure out the long-term adverse event for the eye. And so he's the PI of that study. So you give your patient TB, you enroll her on this study, and she gets 3 months of extra eye exams to make sure that there's no long-standing ocular adverse events. It's cool, and thank you.
Yeah. So this concludes our symposium. I think we're good on time. Thank you, Brad, and thanks for everybody for being here, showing up, having breakfast with us. CME credit for this, yeah.
Is it possible that some of the reps can give up the receipts for the physicians that are attending, that are standing up?
Maybe 20, you don't mind. We appreciate. Yeah, we see later. And we have a Zoom link now that we got set up, so it's up to you. We're gonna have. Do you want to go to Poland and watch it on the Zoom in Rudolshi? So we asked them the first best to, especially remembers to stay here. Good guy. He's there. It's not pretty as well. So I eat as the late back to this live.
So CME credits for this. You'll get an email, a link. Thanks again to AbbVie. And this talk's going to be on demand at GOG website in the future, in the next few weeks. So we'll, with that,